Hi, I'm Ravi Mehta. I'm a professor of nephrology at University of California, San Diego, and delighted to give this presentation. These are my disclosures over the last 2 years. When we talk about dialysis timing in AKI, there is a major dilemma that clinicians face. If you start too early, the intervention may not be needed and there are risks of the procedure. If you wait too long, you may reduce the benefit and there's a risk of irreversible organ failure and death. When we think about decisions for renal replacement therapy, we are constantly characterizing patients with respect to the goals of care, looking at the indications, and then offering the therapy. But these can be differentiated in terms of an elective procedure versus urgent or an emergent life-threatening. And the key thing to consider here is the elapsed time, because as we go from one end to the other, the benefit may go down and the incidence of futility may go up. With this as background, the current practice of renal replacement therapy represents indications that we all agree on and utilize, and these are consistent with the KDIGO recommendations. However, what this lends itself to is that we try and avoid dialysis as much as possible, mostly related to the fact that we consider that the AKI might resolve by itself, there are risks associated with dialysis, and it may not improve outcomes. And these facets have been promoted by the trial information we've received from trials in the past, the ATN trial on the left side and the renal trial on the right side, again showing you that the complications associated with dialysis or placement of access are present, and they may be represented in terms of the risks for unnecessary intervention or the potential for impeding renal recovery. But when you look at these in general, here are the risks for placing an a catheter for hemodialysis. And when you think how common this procedure is in relationship to a central venous catheter, these risks are no different than any central venous catheter, as shown in this cartoon on the right side. So when we think about how we currently address patients, there is the uncertainty which has contributed to this wide variation. And on the left side are the pros we consider for early initiation, and on the right side are the cons, which have to be balanced out. So clinicians are dealing with these issues on a daily basis. Now, over the last 5 years, there have been multiple trials which have looked at this issue of timing. The first trial, the ELATE trial, was single center. And as you can see here, this was shown to have a mortality benefit with early initiation if the dialysis was started within stage 2 early on, within 12 hours or later than that time. The second trial, the Akiki trial, multi-center from France, compared early versus delayed RRT, where they waited for stage 3 to occur or complications, and found that mortality was not different. However, interestingly, about 49% of those people in the delayed group did not require RRT. A third trial, similarly from France, the IDEAL trial, looked at acute kidney injury and sepsis patients with sepsis, and found similarly no difference in mortality, but the need for RRT was reduced to about 38% not needing it. But this trial was stopped early because of futility overall. And then most recently, just published about 2 weeks ago, is the START AKI trial, which was multinational, one of the largest trials in the area of over 2,800 patients. And here again, the mortality difference was not present between the group which was standard care versus an accelerated care. And they did find that 38% of the patients in this group, also in the delayed arm, on the standard arm, did not require dialysis. And as you can see, there were some differences with respect to the adverse events and KRT dependence. Now, if you put all these trials in perspective, it seems that we should be able to hold off on dialysis as long as possible because these patients are likely to not need it in the meanwhile. But I would like to walk you through this table, and it's a little complex, but I want you to focus on just the yellow highlighted areas and on the right side here. in terms of what happens with respect to the scores, the SOFA score, the cumulative fluid balance, and the time difference here. And as you can see in the Akiki and the ideal ICU trial, the time difference between the early and delayed groups is relatively large. And overall, same thing in the START AKI trial, about 25 hours. But what's more important is, even though the 60-day and the 90-day mortality in these trials is no different in the early and delayed group, but when you ask the question, what was the mortality of those patients who were dialyzed in the delayed group, it is much higher in both the Akiki and the ideal trial, and we do not have this information here. Now, why is this important? Obviously, in an intention to treat, you only look at the groups as they're balanced at randomization. However, it's important to know from a patient's perspective what would happen if you waited in that time frame. And there is, in all of these trials, a higher rate of hyperkalemia in the delayed group, a higher rate of fluid accumulation, as you can see here in the START AKI trial, that you have much more fluid accumulation at the time. So this begs the question in this situation is, are these complications contributing to outcome? And this is a study from Liborio et al. Using the MIMIC database, where they characterize the models with respect to, here's the influence of the severity of acute kidney injury. If you add to that hyperkalemia, if you add hyperkalemia and metabolic acidosis, and then you add cumulative fluid balance, you can see that the influence of the severity of AKI is attenuated by these complications, suggesting that these complications have a significant influence on the overall mortality associated with AKI. And since these complications are likely to be influenced and helped by renal replacement therapy, you can ask the question, is renal replacement therapy going to be effective if you have these complications in place? And the answer is yes. So you can see here is metabolic acidosis, hyperkalemia, and or cumulative fluid balance. And in general, a meta-analysis done on the same subject shows you the same aspects of things which have happened, showing you that metabolic acidosis, hyperkalemia are all amenable to the early initiation dialysis itself. So we ask the question is it really okay to wait and see when you start dialysis? And these are my colleagues who contributed to this study. And what we asked, the objectives of our approach was to see is, if we compare a wait-and-see approach to a standard approach, what would happen in these patients? And this is a retrospective multinational cohort study from 4 centers, collected on patients in the ICU from 2014 to December 2017. This is the exclusion criteria. And what we found here was that we characterized these patients as having emergency, urgent, or elective-based dialysis based upon the following criteria. Emergent, when they reach AKI stage 1 or 1 AKI complication the same day or present of 2 complications. Urgent with no complications or no AKI stage 1 complication. And elective when there were no complications. And these were the complications we were looking for. The primary outcome was ICU and hospital mortality, and need for dialysis was a secondary outcome. Here is a table, and I'd like to first point out to you that there's a significant number of patients in each of these groups. And what is interesting to note here is that the number requiring mechanical ventilation, for example, is significantly higher as you go into the elective, urgent, and emergency group as such. And you can see that their SOFA scores are also incremental, and although their underlying comorbidities are also reflective of those who would require emergency dialysis itself. And what's interesting is, in the elective group, there was a high proportion of patients who were dialyzed before reaching AKI criteria. So this means that over 41% of all the dialyzed patients did not really meet these AKI criteria itself, and these are the most frequent complications. But what you see is, more importantly, is the main outcome. So I'd like to first have you focus on just the green squares. But you see, here's the non-dialyzed group in each. As you go from the elective to the urgent to the emergency, the ICU days in the non-dialyzed group increases. And as you go in and look at the mortality, incremental mortality also occurs in the same manner. Now, if you look at the red squares, these are comparing those people who were dialyzed. And again, you see there's a difference which is incremental overall in terms of mortality in these groups. And this is significantly different from those who are non-dialyzed. But what's important is that even in the non-dialyzed groups, you see this difference itself. And this is consistent with this classification of when they were getting dialysis. And this is just graphically representing the same thing. Here's the non-dialyzed on the right side, the dialyzed on the left side. And as you go from the elective, urgent to emergency, there's a trend upwards in each of these parameters itself. When we do a logistic regression, this categorization also helps you see that the dialysis need is influenced by the status of urgent and emergent. And what's more important is that it increases almost a twofold risk for increased risk of dialysis as you go down the status of urgent to emergent. In a regression, multi-regression for mortality, you can see again is there's a significant influence on the odds ratio, and these are the interaction terms, both for ICU and hospital discharge. But to make this more meaningful, I would like to show you how this translates out with respect to a similar analysis as was done by Labori et al. Here's, if you look at the influence on mortality just by the severity score, this is the baseline risk. If you add any complication, this risk is attenuated a little bit, but as any complication is coming into play, and then when you look at the number of complications, it goes back up in a significant manner itself. So what does this actually into how we should evaluate these patients? So we know that it is difficult to determine for an individual patient who does not have an emergent indication as to whether or not it would be prudent to wait or it is important to start right away. What we are finding from our studies on these multi-centers, multinational data sets is that a lot of patients are using dialysis are being dialyzed over a period of time and without meeting ACAT criteria. Reaching the emergency criteria is associated with higher ICU hospital mortality, and the attributable risk of dialysis is being affected by the presence of complication. So we think that it is important for us to weigh in context that the wait and see approach may not be necessarily good for everybody, and we have to recognize that there is a risk associated with waiting too long. Thank you for your attention.